Hi everyone. Good evening and welcome to class. So this is our INI-CET Sure Shot Ophthalmology, and please let me know if I am audible and visible and you're able to see the presentation, and then we'll start. So am I audible and visible? Shall we start with the questions? Good evening. Please tell me if I'm audible and visible. Okay. So see, in today's session, what we'll be doing is we will be taking up a few concept-based questions from the INI-CET previous year's exams, and we'll try to solve them, and we'll try to go through the important concepts. So let me start with this. What is the primary action of the superior oblique muscle of the eye? So what is the action of the superior oblique muscle? So we have the option of depression in adduction, extorsion, intorsion, elevation in adduction. So what is the primary action of the superior oblique muscle? So which is the answer that we should choose? What is the primary action of the superior oblique muscle? Chalo, tell me the answer and then we are going to proceed. Correct. The answer is intorsion. So the primary function of the superior oblique muscle is intorsion. Now this is a very concept based question. So what we'll do is, taking the opportunity of this question, we'll just quickly revise the actions of the eye muscles. So just to quickly revise, there are three axes on which eye muscles are acting, right? So first, if I keep a vertical axis, so if there is a vertical axis, that is, if this is the fulcrum, then along this vertical axis, the two types of movements possible are adduction and abduction, correct? So our main adductor is which muscle? Our main adductor is the medial rectus, and it is very minimally assisted by the superior rectus and the inferior rectus. Whereas the main abductor is lateral rectus, whereas it is minimally assisted by the superior and the inferior oblique. So this is if you keep a vertical axis. So what are we keeping here? We are keeping a vertical axis, and we have two types of movements, adduction and abduction. Now, if we take a horizontal axis, that is, if I keep the fulcrum like this, then what are the different types of movements possible? The different types of movements possible are, we can lift the eye, that is, I can look up, that is elevation and depression, right? Elevation and depression. Now, which are the elevators? The elevators are superior rectus and inferior oblique, whereas the depressors are, inferior rectus and superior oblique. Correct? Now the third is, if I keep an antero-posterior axis. I'm discussing this in a little detail because this is for the INI-CET, that's why. So if I keep an antero-posterior axis, then the two types of movements possible are intorsion and extorsion. So the two types of movements possible are intorsion and extorsion. So see, which are our intorters? We remember is that sin, that is superiors are intorters. So our intorters are SO and SR, and the extorters are IO and IR. Right? So these are the different movements of the eye. So keeping this in mind, we will now quickly revise what are the functions of the extraocular muscles. So let us take all the extraocular muscles, say medial rectus, lateral rectus, medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique and inferior oblique. Superior oblique and inferior oblique. So for medial rectus, we have only one function, and that is adduction. For the lateral rectus, we have only one function, that is abduction. Now I want an answer from you. For the remaining four muscles, that is superior inferior rectus and superior inferior oblique, each one of them will have three functions: primary, secondary and tertiary. So now look at this and tell me what I should write as the primary function of superior rectus, what should be the secondary function, and what is the tertiary function. So for superior rectus, what should I write as the primary function? The primary function of the superior rectus is elevation. The secondary function is intorsion and the tertiary function is adduction. So elevation, intorsion and adduction. So remember, for superior rectus, if we are asked what are the functions, we will write elevation, then comes intorsion, elevation, intorsion and adduction. Elevation, intorsion and adduction. These are the functions of superior rectus. Now, in the same way, if I look at inferior rectus, what are the functions of inferior rectus? The functions of inferior rectus are depression, primary, extorsion and adduction. Depression, extorsion and adduction. So, these are the functions of your inferior rectus. So, what will you say? Depression, extorsion and adduction. Depression, extortion and adduction. Now I want to tell you something which is a little confusing but important, because this is for the INI-CET exam. See, the superior and the inferior rectus, they depress in a position of abduction. They are themselves adductors. Please don't confuse with this. The superior and inferior rectus muscles are themselves adductors, but they elevate and depress in a position of abduction. Meaning, if I abduct the eye and elevate, like for this eye, if I abduct and elevate, it is superior rectus. If I abduct and depress, it is inferior rectus. So they are elevators and depressors in abduction, but they are themselves adductors. So see, the primary function is this is secondary, this is tertiary. So they are themselves, their tertiary function is adduction, but their elevation and depression, that takes place in abduction. Okay, this is for the superior and inferior rectus muscles. Now come to the oblique muscles. For the oblique muscles, if we are asked what is the function, for the primary function of oblique muscles will always be torsional. So rotatory movement is their primary function. So that is why, see, for superior oblique, the primary function is intorsion. Intorsion. Then comes depression. Then comes abduction. Intorsion, depression, abduction. These are the functions of SO. And similarly, if you look at IO, what are the functions? Again, the torsion will be primary. So extorsion, elevation and abduction. Extorsion, elevation, abduction. These are the functions of the IO. So what are the functions? The primary function of SO and IO is torsion. So extortion, elevation and abduction. These are the functions of the inferior oblique. Now here also the catch remains. The oblique muscles are themselves abductors, but they elevate and depress in adduction. Their elevation and depression, this is in a position of adduction. Right? So they elevate and depress in adduction, meaning, see, for this eye, if I adduct and elevate, this is inferior oblique. If I adduct and depress, this is superior oblique. So, see, the superior and inferior rectus muscles, they elevate and depress in abduction. The superior and inferior oblique muscles, they elevate and depress in adduction. Okay? And also remember, for the superior inferior rectus muscles, the primary function will be either elevation or depression. Whereas for the oblique muscles, the primary function will be torsion. So for SO, the primary function is intorsion, and for IO, the primary function is extorsion. Okay, a slightly tough question. So tell me, have you understood this? Shall we go ahead with the next question? Shall we go ahead with the next question? I think you are, yes, I think you have understood, because some of you have been giving correct answers here. Okay, I'll go on to the next question. Which of the following need to be considered when there is a sudden and painful decrease in vision along with red eye? So there is redness and there is a sudden and painful loss of vision. So this has more than one correct answer, okay? So the options are acute hemorrhagic conjunctivitis, acute bacterial keratitis, primary open angle glaucoma, angle closure glaucoma, and acute anterior uveitis. So which are the ones that are correct? So there is a sudden painful loss of vision and there is a red eye. So it's a painful red eye and there is also a loss of vision. So which of the following are we going to consider? There are more than one correct answer. So will you try and then I'll tell you the answer? There's more than one correct answer. So which are the possible correct answers here? Where all do we get painful red eye and we also get loss of vision? Okay, let us look at the options here. So see, for acute hemorrhagic conjunctivitis, this is redness will be there. Here you will have redness. But in conjunctivitis, we don't describe the symptom as pain. It is going to be foreign body sensation, or we can call it as irritation. Foreign body sensation or irritation, but there is no pain. And there is no vision loss. There is no vision loss in conjunctivitis. The patient is having irritation, watering, and maybe because of that slight blurring, but the patient will not complain of vision loss. Let's look at POAG, primary open angle glaucoma. This doesn't have an acute presentation. So there is no redness. It is a loss of vision, but it is gradual and painless. Gradual and painless loss of vision. It is not even loss of vision, it's actually a decrease in vision. Gradual and painless decrease in vision. So these two are not the answers. The other three, like acute bacterial conjunctivitis, this presents with redness, pain and decrease in vision. Similarly, ACG, angle closure glaucoma, this also presents with extreme pain, redness and decrease in vision. Same for acute anterior uveitis. So these three are correct. Acute bacterial keratitis, sudden painful loss of vision and red eye. Acute ACG, again painful loss of vision and red eye. Acute anterior uveitis also. Right? Now, how do we differentiate between these conditions? Acute bacterial keratitis is obviously very obvious because you will have a lesion on the cornea. The problem is when you have to differentiate between ACG and uveitis. So, acute ACG and acute and iridocyclitis, acute angle closure glaucoma, acute anterior uveitis. So, what are the important features that we should know about this? This also is important. It comes as we have to know this. So, both of them are painful red eye, correct? Both of them will have painful red eye and vision loss. Painful red eye and also sudden vision loss. In acute ACG, what is it? This will be an elderly female patient. So acute ACG, usually it is an elderly female patient presenting with a sudden onset vision loss. What will you have? You will have a hazy cornea. You will have shallow anterior chamber. And very, very, very important, mid-dilated and vertically oval pupil. You will have a mid-dilated and vertically oval pupil. And of course, the IOP will be very, very high. The IOP is going to be high. This is acute ACG. How about acute anterior uveitis? Here there is no patient profile. It can be anybody. And you will have keratic precipitates on the corneal endothelium. So what do we have on the corneal endothelium? We have keratic precipitates, which are inflammatory deposits. Next, you will have cells and flare in the anterior chamber. So there are inflammatory cells in the anterior chamber, and there is haziness, which is because of the turbidity of the aqueous humor. And what is the pupil like? This I think you should be able to tell me. This is one of the very, very telltale signs which differentiates acute ACG from anterior uveitis. In acute ACG, I told you mid-dilated vertically oval pupil. In acute anterior uveitis, what is the pupil like? Is it normal? Is it dilated, or is it myosed? Do we have a normal pupil, a myosed pupil, or do we have a dilated pupil? What kind of pupil do we have in case of uveitis? In case of uveitis, yes, in uveitis, we tend to have a myosed pupil, myosed or constricted pupil. Festooned pupil is seen in chronic uveitis, not in acute. After the formation of posterior synechiae, we are going to have a festooned pupil if it is a chronic anterior uveitis, not in acute anterior uveitis. Okay, so here, because of the spasm of the uveitic tissue, we will have a myosed pupil. So see, both of them are examples of a painful red eye with sudden onset vision loss. But here, as I told you, in acute ACG, it's usually seen in elderly female patients. The cornea is hazy, the anterior chamber is shallow. This is very, very important. And there is a mid-dilated vertically oval pupil with a high intraocular pressure. In acute anterior uveitis, there is no specific patient profile. Patient presents with a sudden vision loss and painful red eye. There are keratic precipitates on the corneal endothelium, cells and flare, which means aqueous turbidity in the anterior chamber, and the pupil is myosed. Okay, so both of them are painful red eye with vision loss, but this is how we differentiate. And the third one, which is painful red eye with vision loss, is acute bacterial keratitis, corneal ulcer. But then you will see a lesion on the cornea, so that will tell you it's a bacteria. It is a keratitis. That is going to tell you that it's a keratitis. Okay, so let's go to the next question. Simple question. Which of the following conditions have familial predisposition? Retinoblastoma, POAG, myopia, retinitis pigmentosa, all of the above. What is the answer here? This I think every one of you will be able to answer. This is a simple question actually. Which one should we say? Which of the following has familial predisposition? Retinoblastoma, POAG, myopia, retinitis pigmentosa, all of the above. Correct. It's all of the above. It's all of the above. So retinoblastoma, usually the mode of inheritance is autosomal dominant. For retinitis pigmentosa, we can have all types of modes of inheritance. We can have autosomal dominant, autosomal recessive, and X-linked. The others also have familial predisposition. These have direct inheritance patterns. The others have primary open angle glaucoma and myopia. They have familial predisposition. They do not have distinctive inheritance patterns maybe, but they have familial predispositions. Okay, so all of them have familial predisposition. Sure. Let's go to the next question. In the image below, what is the step of cataract surgery that has been depicted? What is this step? Is it hydrodissection? Is it IOL implantation? Is it lens aspiration? Or is it capsulorhexis? So what is the step that is depicted here? So in the image below, what is the step of cataract surgery that is depicted? Hydrodissection, IOL implantation, lens aspiration, or capsulorhexis. What is this step? I think this everybody will be able to say. What is this? Correct. This is capsulorhexis. This is capsulorhexis. So we are creating a circular opening in the anterior capsule that is called as capsulorhexis. So taking the opportunity of this question, we'll just look through the images of the different steps of cataract surgery. So have a look at this. This is the step of the incision. This is the incision for phacoemulsification cataract surgery. So the most commonly done cataract surgery is phacoemulsification cataract surgery. Phacoemulsification cataract surgery. So I'll just show you the images. We'll just quickly revise them because all of them can come. So see, here we are making an incision. What is the position of the incision usually? It is a temporal clear corneal incision. It's a temporal clear corneal incision. Right? The temporal clear corneal incision, what is the size of this incision usually? The size of the incision is less than 3 mm generally. and it is supposed to be a self-sealing incision so that it is a suture-less surgery. So at the end of the surgery, the incision will seal on its own. You just need to hydrate the wounds. So to make this main incision, we use this blade, and the name of this blade is keratome blade. This is used to make the main port incision. But at the sides also we need to make two small incisions, two small ports here. These are called as the side ports, and this is made with this blade which is called as the MVR blade. This is for the side ports. This is for the side ports. So this is the first step. After topical anesthesia, the first step is the incision. So main incision with keratome blade and side ports with MVR blade. Then is the step that you saw, that is here, creating an opening with the help of this capsulorhexis forceps, which is called as capsulorhexis. So a circular opening will be made like this in the anterior capsule. Now next is this. Now tell me, what is the next step after capsulorhexis? What is this image that you are seeing? Tell me, we can get this also, na? So see, here there is a bent cannula here. You can see that there is a bent cannula and it is attached to a fluid filled syringe. There is a bent cannula which is attached to a fluid filled syringe. And then what we are doing, we are taking this beneath this capsulorhexis margin and we are injecting the fluid. Why? To separate the lens fibers and the capsule. So what is this step called? Please tell me, what is this step called? Where we are injecting fluid beneath the capsulorhexis in an attempt to separate the lens fibers and the lens capsule. So what is this called? Correct. This step is called as hydrodissection. This is called as hydrodissection. Good. This is called as hydrodissection. So after hydrodissection, the lens fibers and the lens capsule are separated. Now I want to remove the cataractous lens. So first I will try and remove the nucleus. So how I will remove the nucleus? With the help of this is called as the phaco probe. So this is our phaco probe, and this phaco probe, it has an ultrasound tip. So the tip is made up of ultrasound here, and here this is attached to the vacuum pump. This is attached to the vacuum pump. So what this tip does, this tip is made up of ultrasound and it emulsifies this lens nucleus. And this vacuum is going to aspirate it. And here along with this, we use another instrument which is called as the chopper. So this chopper will go in through the side port and it will help you to chop the nucleus, and this phaco probe is going to emulsify it and it is going to aspirate it. So this is how we are going to remove the nucleus. So this is called as nucleus management. This is called as nucleus management. The central hard core of the lens is removed with the help of the phaco probe, which has an ultrasound tip, and the tubings are attached to a vacuum pump, and through the side port we will put in this instrument which is called as the chopper. Right? Now to remove the peripheral softer cortex, what are we going to do? We are going to do this, which is called as irrigation and aspiration. Irrigation and aspiration. Irrigation and aspiration is for removal of the peripheral softer part of the lens, which is called as the cortex. So irrigation and aspiration is for cortex removal. Okay, so for this we have this instrument which is called as the bimanual irrigation aspiration cannula. So in this, you see this one, this is your irrigation cannula, and this irrigation cannula, this is attached to the fluid bottle. This is connected to the fluid bottle. So through this irrigation cannula, the fluid is going to flow in, it is going to loosen the cortex, and this aspiration cannula, this is attached. This is the aspiration cannula, and this aspiration cannula is attached to the vacuum pump of the phaco machine. So this is attached to the vacuum and it is going to aspirate. So this irrigation loosens the cortex. So what you see here, see these black things, they are the cortex. The cortex will be loosened by the irrigation and it will be aspirated by the aspiration cannula which is connected to the vacuum pump. So if you get this image, this is irrigation and aspiration with the help of bimanual IA cannula. right? Now once this cortex is also removed, what is left? What is left is IOL insertion and dialing. So this image is IOL insertion and dialing. IOL insertion and dialing. So what do we do? Here what you see here, this is this yellow thing that you see, this is your foldable IOL. So this foldable IOL, because this incision is very small, that's why the IOL is folded and it is placed inside this IOL injector. So this is the IOL injector. So you fold the IOL, you load the IOL inside the injector and you take it inside, and as you press the plunger, this IOL will go inside and it will unfold. So you will be able to place the IOL through this small incision. But then in order to place the IOL into the capsular bag, you need to use this. This is called as your IOL dialer. Looks very similar to the chopper, but the tip is not so sharp or big. It has got a very small tip. So this is the IOL dialer. With the help of this dialer, you are going to dial this IOL into the capsular bag. Right? So I just want you to have a look at all these images, because if capsular access can be asked, all the other steps can also be asked. So see, the first one is the incision, and please look at the instruments: keratome blade, MVR blade. Next is capsular access. Third you told me is hydrodissection. Then nucleus management with the help of phacoprobe and chopper. Then irrigation and aspiration for removal of the peripheral cortex with the help of bimanual irrigation aspiration cannula. And then insertion of the foldable IOL with the help of the IOL injector and dialing it with the help of your IOL dialer. Okay, so these are the different steps of phacoemulsification cataract surgery. Okay, shall we go to the next question then? Sure, let's go to the next question. Very simple question. Which is the most common ocular manifestation of COVID-19? Is it pseudomembranous conjunctivitis? Is it viral keratoconjunctivitis? Is it follicular conjunctivitis? Or is it retinal vein occlusion? So which of these is the most common ocular manifestation of COVID-19? Which of the following is the most common ocular manifestation of COVID-19? Is it pseudomembranous conjunctivitis, viral keratouveitis, follicular conjunctivitis, or retinal vein occlusion? Correct, it is follicular conjunctivitis. Now see, keratouveitis, retinal vein occlusions, retinal artery occlusions, all these are also seen in COVID. So in COVID, vascular occlusions like central retinal artery occlusion, central retinal vein occlusion, keratouveitis, all these are also seen, but they are not the most common ocular manifestation. So the most common ocular manifestation of COVID-19 is follicular conjunctivitis. Next question. Now this is something I want you to know properly. Which of the following has been depicted in the image that's given below? What is this investigation? Is it a Hess chart? Is it ETDRS chart? Is it a Snellen's chart? Or is it Pelly-Robson chart? Which of the following has been depicted in the image below? So what is this? Is it Hess chart? Is it ETDRS chart? Is it a Snellen's chart? Or is it a Pelly-Robson chart? So which of the following is this? Correct. This is a Hess chart. This is a Hess chart. Now see, this ETDRS chart and Snellen's chart, these are visual acuity charts. They are used to check your visual acuity. And this Pelly-Robson chart, this is a contrast sensitivity chart. This is used for evaluation of contrast sensitivity. And what is this Hess chart used for? The Hess chart is used for evaluating. It is used in different types of paralytic squints actually. You can use it in paralytic squint. So see, I'll just show you a little bit. This is a normal Hess chart which is showing you the functions of the different extraocular muscles. This is the right eye and this is the left eye. So see, these are the different positions. Okay, so adduction, abduction. So this is showing us the functions of the different extraocular muscles. Now see, I'll show you, if you look at this, this is also a Hess chart. Okay, this is also a Hess chart. This is the right eye and this is the left eye. Now, when we look at a Hess chart, the first thing we have to see, if we are asked which is the abnormal eye here, the simplest method is the one which has the smaller box. That is your abnormal eye. Okay, the one which has your smaller box, that is the abnormal eye. So here the abnormal eye is the right eye because the box here is smaller. Now this is showing you the functions of the extraocular muscles. So see, this is nasal, this is temporal. This is temporal for this side. This part is nasal, this is temporal. Now I told you the smaller box that represents the abnormal eye. Now so you know that the right eye is abnormal. Can you tell me which is the movement that is affected here in the right eye? The answer is simple actually. If you see which box is smaller, which side the box is smaller, you will realize which is the movement affected. That is the simple way to look here. Look at this. So tell me, in the right eye, which movement is affected? On which side is that box smaller? As a general common sense question, this is not likely to come in the exam, but just in case it does. Very good. It is abduction. So see, this box is smaller on the lateral side. So it is the abduction of the right eye which is affected. So now tell me, this represents what palsy? This represents what palsy? This represents what palsy of the right eye? The abduction is affected. Correct. So which it represents which palsy of the right eye? I'll just wait for a couple of minutes. Think and say, if the abduction is affected in the right eye, which is the muscle affected? Correct. So this is basically 6th nerve palsy of the right eye. So it is 6th nerve palsy of the right eye. And you can see that there is an overaction of the yoke muscle. So see, in this left eye, you can note an overaction of the yoke muscle, which is the contralateral medial rectus. Because there is a palsy here, you can note there is an overaction of the yoke muscle of the left eye. But don't get confused when you look at the bigger box. The way to read the Hess chart is look at the smaller box. The smaller box is going to tell you which is the abnormal eye. So here the smaller box is on the right side. So it is the right eye is abnormal. And on which side do we have the box is looks to be not complete. It is the abduction is the movement affected. So it is the lateral rectus which is affected. Okay, and then if you look at the other eye, you will realize that the yoke muscle of the other eye is showing an overaction, which is the medial rectus of the left eye. Okay, now try this one. This also, I think don't look at the bigger box. Look at the smaller box and try to say which is this is the right eye and this is the left eye. So we all understand that the right eye is the eye which is affected because it is smaller. Now can you tell me which is the only movement that appears to be normal here? Which is the only movement that appears to you to be normal in the right eye, which is the smaller box? Which is the only movement that appears to be normal? See here these dots that you see, they are representing your normal position. These dots, see, look at these dots. This is the normal position. Okay. So on all sides, you will see that this box is small. So, but it is normal on one side, which is the correct. The only movement that seems to be unaffected is actually abduction. But on all the other sides, the box is small. Only on this side, see, in the side of abduction, you feel that the box is not small. So the abduction seems to be normal. Everything else seems to be affected to a certain extent. So using this is a retrograde way of looking at it. Can you tell me this is what? Correct. This is third nerve palsy. This is third nerve palsy. So see, if you look at the smaller box, it is not very difficult to understand what is the problem. So here you understood in this that everywhere the box seemed to be normal. Only see on the side of abduction, you saw that the box was smaller. So you realized abduction is affected and it is 6th nerve palsy. In the other box, it was, in the other picture, it was like the opposite. You look at the smaller box, you realize that the box is small on all sides, only the abduction seems to be at the normal place. So abduction is spared, so this is likely to be a third nerve palsy. Right? So now I think you have understood the basics of Hess chart. You will be able to do basic things if it comes in the exam. Right? Chalo, let's go to the next one. A 25-year-old female came to the emergency ward with sudden and painful loss of vision, which is associated with RAPD, and the opposite eye is found to be normal. So it's a unilateral condition. There is a sudden loss of vision, there is pain, and there is RAPD, which basically suggests, what does RAPD suggest? It suggests that it is the optic nerve which is affected, because not always, but RAPD means that there may be a problem with the optic nerve. Now, which of the following tests needs to be recommended for the patient? What do we do for this patient? Do we ask for a thyroid profile? Do we ask for NMO and anti-MOG antibodies? Do you ask for MRI of brain and orbit or blood glucose? And it's a female patient, a young female patient. So first of all, we have to understand that there is a sudden loss of vision associated with pain, and there is relative afferent pupillary defect, which is suggestive of some involvement of the optic nerve. So what is our diagnosis? What is the diagnosis? The diagnosis is probably optic neuritis. That is what they are trying to tell us. They should have given us the fundus picture also, but they have not given. So this is optic neuritis. And one of the important causes of optic neuritis. So the question, to establish a diagnosis of optic neuritis, what do we have to do? We have to do a perimetry and we have to do a VEP, that is visual evoked potential. So this is what we should do to first establish the diagnosis of optic neuritis. So what are we going to see in perimetry? We are likely to see a central or a centrocecal scotoma. We are likely to see a central or a centrocecal scotoma. And what are we going to see in VEP, which is the investigation of choice? This is your investigation of choice, right? That is VEP. What are we going to see? We will see that there is an increase in the latency of the P100 wave of VEP. There is an increase in latency of the P100 wave in the VEP. So that is what needs to be done first. Establish that it is optic neuritis by doing a VEP, which is going to show an increase in the latency of the P100 wave. And if you don't have VEP, at least we have to do a perimetry to show that there is a central centrocecal scotoma. And once you're sure that is optic neuritis, then what is the important cause of optic neuritis, especially if it's a female patient? We have to rule out the demyelinating disorders. We have to rule out the demyelinating disorders. So that is why we have to do an MRI of the brain and the orbit, and we have to rule out demyelination. Because conditions like multiple sclerosis, neuromyelitis optica, demyelinating disorders, their primary, especially in MS, the primary presentation may be with optic neuritis. So that's why we have to look for demyelination in these patients, and that's why the answer is MRI of brain and orbit. But the question seems a little incomplete to me, because first you have to establish its optic neuritis before you order for an MRI of brain and orbit. So first we have to establish optic neuritis by doing VP and perimetry, and then you can try and look for demyelination by doing an MRI of brain and orbit. Okay, and I think what they should have mentioned here is, they should have mentioned that there is RAPD, but the fundus is normal. They should have told us this. The fundus is normal. If they say, what does it mean? It means that it is a case of retrobulbar neuritis. Retrobulbar neuritis, which is the common type of optic neuritis that we get to see. So retrobulbar neuritis, that means the portion of the optic nerve which is behind the globe, that is inflamed. That's why when you do a fundus examination, the fundus will be normal. The disc and the macula will be normal. So they should have mentioned that also in the question, that there is RAPD but the fundus is normal. So that would have told us it is RBN. Okay, chalo. Let's go to the next question. Very simple question. Which of the following has been depicted in the image that is given below? Very, very, very simple. I think everybody will be able to answer this. What is this? Is it a Fleischer ring? Is it a KF ring? Is it a Vossius ring or Weiss ring? What is this? Which of the following has been depicted in the image here? Which of the following is depicted here? Is it Fleischer's ring? Is it KF ring? Is it the Vossius ring? Or is it the Weiss ring? Correct. This is the Vossius ring, which is seen when you have a blunt trauma. Very, 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 very typical. When you have a blunt trauma, then when the iris goes and hits the anterior surface of the lens, then when it touches the anterior surface of the lens, then the iris pigments, they can be left behind on the anterior lens capsule, and this forms this kind of a ring on the anterior capsule, a brownish ring of iris pigments, which is called as your Vossius ring. And sometimes if it is a severe trauma, then you can also, with the Vossius ring, you can also get a cataract. What is that cataract? That is called as a rosette cataract. So you can get a Vossius ring may be associated with a rosette cataract. Okay, let's go to the next question. A patient, very, very simple. A patient presents with the following field defect. What is the expected lesion in the visual pathway? So, is the site of the lesion the optic radiation? Is it the optic tract? Is it the optic nerve? Or is it the optic chiasma? So, this is the visual field defect of the patient, and we are being asked what is the site of the lesion. Is it the optic radiation? Is it the optic tract? Is it the optic nerve? Or is it the optic chiasma? What is the site of the lesion? Correct. Very, very simple it is. See, whenever you get this, we have to first, to be able to give the answer correctly, first what we have to do? First we have to write down which is the right and left, and remember the right and left are to be written according to your own right hand and left hand. Don't get confused. When you draw a picture of the eye like this is right and this is left, but when you look at a perimetry printout, now this is right and this is left. Make no mistake. In this picture it doesn't matter, but when I show you the other pictures it will start mattering. So here, see, for each of them, this is nasal, this is temporal, this is nasal, this is temporal. So we can see that the temporal fields of both the eyes are affected. So as you have correctly told me, this is a bitemporal hemianopia. It is a bitemporal hemianopia. So the site of the lesion is the midline structure, that is the optic chiasma. So there is no problem with this because there is no right and left associated with it. The problem arises when you have a right and left associated, because this is a midline structure, there is no right or left to it. So that's why the answer becomes simple. It is optic chiasma. Now have a look at this. If we get this in the exam, what is the site of the lesion? So now see what we are going to do is, we are going to first mark out this is right and this is left, okay, and this is nasal, this is temporal. So see, the nasal field of the left eye and the temporal field of the right eye are affected. So the nasal field of one eye and the temporal field of the other eye, these are affected. So this is called as homonymous hemianopia. What is it called? It's called as homonymous hemianopia. Now comes the tricky question. If I ask you, what is this? Is it a right homonymous hemianopia or is it a left homonymous hemianopia? Will you say this is a right homonymous hemianopia or left homonymous hemianopia? Would you say that it is right homonymous hemianopia or left homonymous hemianopia? Now see, the nasal part, the nasal field of the left eye and the temporal field of the right eye, both of them are on your right hand side. See, the nasal field of the left eye and the temporal field of the right eye, both of them are on your right hand side. So this is a right homonymous hemianopia. I'll repeat this once more. See, first mark out the right and the left, then mark out the nasal and temporal, then see, it is a homonymous hemianopia because the nasal field of the left eye and the temporal field of the right eye are affected. And this is a right homonymous hemianopia because see, the nasal field of the left eye and the temporal field of the right eye are both on your right hand side. So this is a right homonymous hemianopia. So then the site of the lesion is the left optic tract. Okay, so the site of the lesion is the left optic tract. So if it is a right homonymous hemianopia, site of lesion is the left optic tract. So now see, it becomes very, very, very important to understand which is right and which is left. Okay, now look at this next picture. Again, please mark out the right and the left. This is right, this is left. Again, nasal, temporal, nasal, temporal. So what is this defect and what is the site of the lesion? What is the defect and what is the site of the lesion? What is this defect and what is the site of the lesion? What do we call this? It is a type of homonymous hemianopia only, but it is not complete. So there is a superior homonymous hemianopia. So correct. This is called as the pie in the sky defect. Once again, see what kind of pie in the sky is it? It is a right-sided pie in the sky defect. Right-sided pie in the sky defect, okay, because it is on the right hand side. So the site of the lesion is the left-sided temporal lobe, the left-sided temporal lobe, or you can say the left-sided Mayer's loop. The site of the lesion is the left-sided temporal lobe, or it is the left-sided Mayer's loop. So pie in the sky, temporal lobe or Mayer's loop. Okay, now the opposite of this is this. Once again, we need to mark out the right and the left and the nasal and the temporal. So what are we going to call this? This is a right-sided, because see, the blackening is again on your right hand side. So this is a right-sided pie on the floor. This is a right-sided pie on the floor. So the site of the lesion is the left-sided parietal lobe, or we can say the left-sided Baum's loop. The left-sided parietal lobe or the left-sided Baum's loop. Okay, so this is where the right and the left become so important. So see, this is the right-sided pie in the sky. So site of lesion, left temporal lobe or left-sided Mayer's loop. And here this is a right-sided pie on the floor. So the site of the lesion is the left-sided parietal lobe or the left-sided Baum's loop. Okay, now the last one I am not going to tell you. You will tell me by yourself. What is this? This is again right and this is left. This is nasal, this is temporal. Nasal, temporal. So this is also a homonymous hemianopia, because see, the nasal part of left eye and the temporal part of the right eye are affected. But here at this central portion is clear. So this is a homonymous hemianopia with macular or central sparing. So again, I will not tell you, you tell me what is the site of the lesion. What is this? What is the site of the lesion here? Macular or central sparing. I will not tell you this. Correct. So it is occipital lobe, but right or left? That is what is important now. So what should I call this? Is it a right-sided homonymous hemianopia with central sparing or left-sided homonymous hemianopia with central sparing? Obviously, again, see, the blackening is on your right-hand side. So it's a right-sided homonymous hemianopia with central sparing. So what is the site of the lesion? Very good. The site of the lesion is the left occipital lobe. So it is a left occipital lobe which is involved. And which is the blood vessel? It is an infarct in the territory of the PCA, that is the posterior cerebral artery. So it's a PCA territory infarct. So the site of the lesion is the left-sided occipital lobe and it is a PCA territory infarct. Okay, so now I hope that you will not confuse between right and left, because this is the only place where students get this question wrong. So most of you know how to identify bitemporal hemianopia, homonymous hemianopia, pie in the sky, pie on the floor, and central sparing. Where people make a mistake is they kind of are not able to understand whether it is right or left. So see, if it is a right-sided homonymous hemianopia, right-sided pie in the sky, right-sided pie on the floor, the site of the lesion is on the left side. Okay, so now look at this. From the image below, identify the site of the lesion. So tell me, what will you say? Left optic tract, left occipital lobe, optic chiasma, or right occipital lobe? What is our answer? We have just about done this. What is this? What is the site of the lesion? Left optic tract, left occipital lobe, optic chiasma, or right occipital lobe? What is the site of the lesion? Correct. We just did this. This is a right-sided homonymous hemianopia with central sparing. Right-sided homonymous hemianopia with central sparing. So obviously the site of the lesion is the left occipital. Okay, so repeat question actually, very similar, and this keeps coming again and again in different exams. So this is like one of the things that has got a very high likelihood of getting repeated. Chalo, let's go to the next question. Diagnosis from the clinical photograph. What is this? What is the most probable diagnosis? Is it a 6th nerve palsy, 4th nerve palsy, 3rd nerve palsy, or MR palsy? What is the most probable diagnosis? 6th nerve palsy, 4th nerve palsy, 3rd nerve palsy, or MR palsy? See, this is a 9-gaze photograph. So when you have a 9-gaze photograph, it's very easy to get confused. So to prevent ourselves from getting confused, what do we have to do? We have to look at this central picture. This is going to give us the most important information. So we have to first look at the central picture, which is the primary position. So when in the 9-gaze photograph, if you look at everything, you will get confused. So look at the central picture. That tells you which is the abnormal eye. The abnormal eye is obviously the left eye. What are the things that you see in the left eye? You see that there is a severe ptosis in the left eye. And look at the position of this eyeball here. What do you see? The eyeball is down and out. Eye is down and out. These two things you can make out from here. There is a severe ptosis and the eye is down and out. Now you look at all the movements. So the upper pictures are going to show you elevation. The lower pictures are going to show you depression. This side is going to show you adduction for this left eye, and this side is going to show you abduction for the left eye. So this is adduction for the left eye. This is abduction for the left eye. Okay, so if you look at this picture, you will realize that it is only the abduction movement of the left eye which appears to be normal. All the other movements of the left eye, they seem to be affected to a certain extent. It is only the abduction which seems to be completely normal. Okay, depression is also reasonably normal and abduction seems to be completely normal. So this is basically third cranial nerve palsy. And this depression is reasonably okay because the SO is spared and the SO is a depressor, and here the LR is spared and the LR is an abductor. So these two muscles are spared because the third nerve is supplying all the extraocular muscles except the lateral rectus and the superior oblique. Now the superior oblique is a depressor, so that's why the depression is fairly okay, and the lateral rectus is an abductor, so that's why you see that the abduction is okay. The rest of the movements are all affected. But this is the second thing you should look at. First, you have to look at the primary position, that is the central picture. When you look at the central picture, you realize there is a severe ptosis and the eye is down and out. The moment you see this, the third nerve palsy strikes you. Then to confirm it, you look at the other pictures. So what do you see when you look at the other pictures? You see that the elevation, adduction, these are affected. Depression and abduction seem to be normal. So the depression is done by the SO, which is spared, and the abduction by the LR, which is also spared. So this is actually third cranial nerve palsy. Okay, so lesson learned, always look at the primary photograph. That is going to give you the answer. Look at the next one. Very simple question. Regarding the safe strategy for trachoma, which of the following is not a component of the strategy? Surgery, evaluation, facial hygiene, antibiotics. So which is not a part of the program? S for surgery, A for antibiotics, F for facial cleaning, and E for evaluation. E is not for evaluation, so this is wrong. E is for environmental modification. Environmental modification. E is for environmental modification. So this is wrong. S is surgery, A is antibiotic, F is facial hygiene, and E is environmental modification. E is not evaluation. Okay, so this is this is one of the easier questions. Next question, a question that has been asked n number of times, but high likelihood of being asked again. A patient came to the opthal OPD with redness and pain in the eye after trauma with vegetative matter. On examination, there is a dry looking ulcer with feathery margins and hypopion. What is the possible diagnosis? What are the pointers in the question? The pointers in the question are: there is a trauma with vegetative matter, there is a dry looking corneal ulcer, and the margins are feathery. So what is the possible diagnosis? Correct. Again, simple question, it is a fungal corneal ulcer. Why? Because in fungal corneal ulcer, there is usually, if they mention that there is a preceding history of trauma with vegetative matter, or they mention that there is more than one lesion, that is, there is one large lesion and there are smaller lesions called satellite lesions. Next, if they mention that the margins are feathery, or they say that the margins are fuzzy, these are the telltale words, or ill-defined margins, feathery, fuzzy and ill-defined margins, and if the surface of the ulcer is described as dry or leathery surface. If these words are mentioned in the question, then it is likely to be a fungal corneal ulcer. And here they have mentioned that there is a hypopion. The typical description for fungal hypopion is fixed. It is a fixed hypopion, meaning it does not move when you change the position of the head. Okay? Now let us just quickly revise what are the telltale points that they say in case of bacterial corneal ulcer. For a bacterial corneal ulcer, usually the question will say that it is a single lesion. As I told you, in fungal, the word satellite lesions or multiple lesions may be there. Here it's a single lesion, right? And then what do we say? The margins are generally are well defined or sharp margins. So single ulcer with well defined margins, and if there is a hypopion, it is a mobile hypopion. The hypopion is usually mobile. That is, if you change the position of the head, it is not that dense, it tends to move. So if these words are mentioned, we will mark bacterial, and if these words are mentioned, satellite lesions, feathery margins, dry surface, leathery surface, fixed hypopion, we will mark fungal ulcer. Okay, many times this has been asked, and it's very high likelihood of being asked again. I'll just show you a couple of images. Now have a look at this here. If you get image A or B, look at A. If you get A, what do you think is more likely? Is it bacterial or is it fungal? Is it bacterial or is it fungal? Look at A, the first one. Should we say bacterial or fungal? The first one, that is A. Okay, see, in the first one, this is more likely to be a bacterial corneal ulcer. This is more likely to be a bacterial corneal ulcer. Why? Because see, there is a single lesion and the margins are very sharp. You have sharp margins or well-defined margins. This is more likely to be bacterial. However, if you look at this one, if you look at the margins are like this, right? Look at the margin here, it's like this. The margins are kind of poking into the surrounding cornea. So this is more likely to be a fungal corneal ulcer. This is more likely to be a fungal corneal ulcer. There is only a single lesion here also, but the margins are somewhat like this. They are extending into the normal cornea. Okay. Now have a look at this image. This, if you get, what will you say? This is image number C. Will you call this as bacterial or fungal? This I think everybody will be able to answer. Should we call this as bacterial or fungal? Should we call this as bacterial or fungal? This I think everyone will know. See, apart from the main lesion, you have these smaller lesions, right? So because of the presence of these smaller lesions, which are your satellite lesions, so there is one large ulcer like this, and then there are smaller ulcers like this, smaller lesions like this. So because of the presence of these satellite lesions, this is a fungal corneal ulcer. This is a fungal corneal ulcer. So those telltale points that we memorize, the same thing can be asked in the form of an image also. So they need not say all these words. They might just say there is pain, redness, photophobia, and the clinical picture is given. They might say one or two things and the rest they may not say, and they might give this image. Okay. So if we have a bacterial ulcer, you will have a single lesion and the margins will appear to be sharp. That is, you will be able to fairly make out where the ulcer is ending and where the normal cornea begins. Whereas in fungal ulcer, look at the margin, it's kind of poking into the normal cornea. And here it is very, very telltale because of the presence of the smaller lesions, that is the satellite lesions. Okay, chalo, let's go to the next question. Again, simple one-liner. Which of the following is the most common tumor of the lacrimal gland? Simple question. Simple one-liner. Which is the most common tumor of the lacrimal gland? Which is the most common tumor of the lacrimal gland? Mucoepidermoid carcinoma, adenoid cystic carcinoma, pleomorphic adenoma, or basal cell carcinoma. Correct. I think you know the answer. It is pleomorphic adenoma. So the most common tumor of the lacrimal gland is pleomorphic adenoma. Let's go to the next question. In a patient, aqueous flare and KPs were observed and the intraocular pressure was found to be elevated. The anti-glaucoma drug that needs to be avoided in this patient is PG analogs, carbonic anhydrase inhibitors, mannitol, or beta blockers. So which is the anti-glaucoma drug that needs to be avoided in this patient? So prostaglandin analogs are there, carbonic anhydrase inhibitors, mannitol, and beta blockers. So first of all, what is the diagnosis? So see, they have mentioned there is flare, aqueous flare, and keratic precipitates, right? So this is uveitis. And with the uveitis, the pressure is also found to be raised. So it is glaucoma. So combining uveitis and glaucoma, the diagnosis here is uveitic glaucoma, the other name for which is inflammatory glaucoma. So uveitic glaucoma or inflammatory glaucoma, this is the diagnosis. So basically the question is asking which is the drug that is contraindicated in uveitic glaucoma. So which anti-glaucoma drugs? I think you know the answer. The answer is this, PG analogs. So it is not only PG analogs. So which are the anti-glaucoma drugs which are to be avoided in case of uveitic glaucoma and why? So let's learn that out. See here, what you need to understand is the PG analogs. Which are the PG analogs that we use? The PG analogs that we use are latanoprost, travoprost, and bimetoprost. This and the alpha receptor agonist that we use, that is brimonidine. These also, they need to be avoided. Why this needs to be avoided? Because both of them, they increase the intraocular inflammation. They increase the inflammation and they increase the risk of causing cystoid macular edema. So uveitis anyway causes cystoid macular edema. These drugs, they further increase the chance of causing cystoid macular edema. So that's why both PG analogs and the alpha receptor agonists that we know. So the PG analogs, we have latanoprost, we have travoprost, and we have bimetoprost. Latanoprost, travoprost, and bimetoprost. So all these, they are to be avoided in uveitic glaucoma, and brimonidine, which is our alpha receptor agonist. Also, theoretically, pilocarpine is to be avoided. We don't give pilocarpine that commonly as an anti-glaucoma drug, but theoretically, pilocarpine is also to be avoided. Why? Because it increases, again, it increases the inflammation, or it increases the inflammation, and also it increases the ciliary spasm. So already in uveitis there is ciliary spasm, and this pilocarpine further increases that ciliary spasm. So pilo is also avoided. Theoretically it is to be avoided, but pilo usually is not given in the first place. But theoretically these are the three classes of drugs that are to be avoided: PG analogs, alpha receptor agonist, and pilocarpine. Okay, chalo, let's go to the next question. In POAG, which of the following drugs can be used in the management of primary open angle glaucoma? Again, very simple question. Physostigmine, phenylephrine, latanoprost, pilocarpine. Which of the following can be used in the management of POAG? So, which is our answer? Physostigmine, phenylephrine, latanoprost, pilocarpine. Which of the following can be used in the management? I think all of you know the answer to this question. Yes, the answer is obviously latanoprost. It comes under our PG analogs. It is the PG analogs. So the PG analogs, they are one of very common in the use of primary open angle glaucoma, because they cause maximum IOP reduction among all the topical medications. They cause maximum IOP reduction among all topical medications. So that's why they are preferred in glaucoma, in primary open angle glaucoma. Now, pilocarpine is also one of, and what is the mechanism of action of PG analogs? They increase the uveoscleral outflow, right? They increase the uveoscleral outflow for the aqueous humor, and they decrease the intraocular pressure. Now, this pilocarpine is also an anti-glaucoma drug, but it is not that commonly used in POAG. It can be used in POAG also. In POAG, it helps to increase the outflow through the conventional pathway, that is the trabecular outflow. So it helps to increase the trabecular outflow, and it can be used in POAG, but its main application is actually not POAG. Its main application is in angle closure glaucoma. So its main application is it constricts the pupil and breaks the acute attack of ACG. So its main application is actually not in POAG. Its main application is in ACG, angle closure glaucoma. So pilocarpine is also an anti-glaucoma drug. Pilocarpine also increases trabecular outflow and can be used in POAG. But the main application of pilocarpine is not in POAG, it is in ACG, that is acute angle closure glaucoma, and that is where it constricts the pupil and breaks the acute attack. So that's why we are choosing latanoprost, because main application of latanoprost is in POAG, but main application of pilo is in ACG. Okay, let's go to the next question. Now this is actually not a question from the INI-CET exam, but it's a very good question, and that's why I thought I'll just do this. A 25-year-old man comes to the OPD for refraction. He is using -3 diopter sphere in the right eye and -2 diopter sphere in the left eye. And what is the expected movement of the retinoscopy reflex in his right eye? So does it move in the same direction as the retinoscope, opposite direction of the retinoscope? Does it move only in the vertical axis, or does it move at all? So which is the option that we should choose? So see, it's a 25-year-old man, which means that the refraction is likely to be fairly stable. So the glass prescription is likely to be the same only. That is -3 in the right eye and -2 in the left eye. So what is the expected movement of the retinoscopy reflex in the right eye? That's what they are asking. Same direction, opposite direction, movement only in one axis, or there is no movement. So chalo, think and tell me. Okay, the answer is this, that is B. The answer is B, that is it moves in the opposite direction. It moves in the opposite direction. That is the answer. Now see, I'll tell you how to arrive at the answer. Now this is a 25-year-old man, meaning his refraction is likely to be fairly stable, meaning it will be -3, -2 only. It's not likely to have too much of a change. Right? Now, see, they have not told us about any cycloplegic, which means that no cycloplegic was instilled. And they have also not told us what is the direction, what is the distance of refraction. So we have to assume that is a standard 1 meter distance. So assuming these two, what do we know? Where do we get no movement? Where do we get with movement? And where do we get against movement on retinoscopy? See, where are we going to get an against movement? What are the conditions where you get against movement? Against movement you will get if you have a myopia which is more than -1 diopter. Where are you going to get no movement? No movement I am going to get if there is a myopia which is equal to -1 diopter. And where am I going to get a with movement? So where am I going to get a with movement? I will get a with movement when we have a myopia which is less than -1, or if I have got emetropia, or if I have got hypermetropia. So hypermetropia, emetropia, myopia less than -1. These are the conditions where I'm going to get a with movement. So when you do a refraction with no cycloplegia and at a 1 meter distance, then against movement means myopia more than -1. No movement means myopia equals to -1, and with movement means hypermetropia, emetropia, or myopia less than -1. So here, see, in not just the right eye, but in both eyes, the myopia is more than -1. See, right eye is -3 and left eye is -2. So both eyes the myopia is more than -1. So which means that in both eyes, what am I going to get? I am going to get an against movement. And what do we mean by against movement? Against movement means that the reflex moves opposite to the direction of the retinoscope. So if the retinoscope is moved in this direction, the reflex will move in the opposite direction. So because not just in the right eye, in left eye also we are going to get an against movement, because both eyes the myopia is more than -1. Okay. So this is actually a question from an FMG exam, but it's a very good question. So I just thought that I'll discuss this. Chalo. Now I have a few questions which are like new questions, but which are good conceptual questions. So I just thought we will discuss these. So look at this. A patient on post-op day 5 after cataract surgery is developing this condition. So the first one is your clinical picture and the second one is your USG-B scan. A patient on post-op day 5 after an uneventful cataract surgery is presenting to us like this. So the first one is our clinical picture and the second one is the USG-B scan. Now the treatment includes all except pars plana vitrectomy, topical antibiotics, IV antibiotics, or intraocular antibiotics. So what do we not do in this condition is the question. So first of all, I want you to tell me, what are you going to say this is? What is the diagnosis? The patient underwent a cataract surgery and then he developed this. The patient underwent a cataract surgery and then he developed this. So look at this, you can see that there is redness, there is a hypopion here, there is a lot of fibrin in the anterior chamber. So this is endophthalmitis. This is post-operative endophthalmitis. And how do I confirm it? I confirm it by doing a B scan. Why? Because I am not able to see the fundus. It is so hazy that I am not able to see the posterior segment. So I will do a B scan. And when I do with a B scan, what am I seeing? You are seeing exudates in the vitreous cavity. So see these haziness. This vitreous cavity here, this is supposed to be hypoechoic, but it is hyperechoic. So there is evidence of vitritis or exudates. So this is going to tell us that it is endophthalmitis. So in endophthalmitis, what do? We will give topical antibiotics. We will give intraocular antibiotics, meaning how do you give? By intravitreally. We give intravitreal injection of antibiotics. So you give topical antibiotics, that is eye drops, and you give intravitreal, that is you inject antibiotics into the vitreous. And if this doesn't work, then the next option is to cut and remove the vitreous, that is pars plana vitrectomy. So eye drops, antibiotics, antibiotic injection into the vitreous cavity, that is intraocular antibiotics, and pars plana vitrectomy, all these are done. But there is no role of intravenous antibiotics in the treatment of endophthalmitis. So please remember this, intravenous antibiotics have no role in the treatment of endophthalmitis. So how did we identify it is endophthalmitis? The patient presents with a painful red eye. You see there is hypopion, it is hazy, the anterior chamber, there is a membrane in the pupillary area, and you are not able to see the posterior segment. So you do a B scan, and in the B scan you see evidence of the echoes in the vitreous cavity, suggestive of vitritis or vitreous exudate. Okay, treatment, eye drops, antibiotic eye drops, antibiotic injection intravitreal, and if this doesn't work, then surgery, that is pars plana vitrectomy, but there is no role of intravenous antibiotic. Okay, chalo, let's go to the next question. This is also a new question. A patient came with the complaint of curtain falling in front of the eye after blunt trauma, and there is a giant retinal tear. What should be the line of management? Should we do a scleral buckling? Should we do pan-retinal photocoagulation? Should we do a pars plana vitrectomy with endophotocoagulation, or should we do a pneumatic retinopexy? Okay, I'll tell you the answer to this question. I told you these are new and difficult questions. So see, what is the diagnosis? The diagnosis is, see, curtain falling in front of the eye and giant retinal tear. So these are the telltale words. So what is this? This is a rhegmatogenous retinal detachment. This is a rhegmatogenous RD, correct? This is a rhegmatogenous RD. So here there is a giant retinal tear. So this is what giant retinal tears look like. This is GRT, giant retinal tear. Now, why I wanted to discuss this question is, what is the surgery of choice for rhegmatogenous RD? If I ask you, what is the surgery of choice for rhegmatogenous RD? Then your answer should be scleral buckling surgery. So the answer should be, for a rhegmatogenous RD, what is the surgery of choice? The surgery of choice is scleral buckling surgery. That is the answer. But if you have a fresh reg RD, with a superior break, where the break is superior, then there is the option of going for pneumatic retinopexy. So where are we going to mark pneumatic retinopexy as the answer? If the question says that there is a fresh rhegmatogenous RD and the break is superior. So normally in a question of rhegmatogenous RD, the surgery of choice to be marked should be scleral buckling. If the question says that there is a fresh RD and there is a superior break, we mark pneumatic retinopexy. But then why we are marking pars plana vitrectomy with endophotocoagulation here? Because here the question is, if you have, say, there is a reg RD where they say that there is a posterior break, that is the break is close to the disc and macula, or there is a giant retinal tear, in these conditions, or there is a giant retinal tear, then the answer is pars plana vitrectomy with Endophotocoagulation. Okay, so that is why here we have to mark pars plana vitrectomy with endophotocoagulation as the answer. So I want you to learn this, that normally in a question of rhegmatogenous RD, if we are asked what is the surgery of choice, the answer is scleral buckling surgery. Only in case of fresh reg RD, if there is a superior break, you can go for pneumatic retinopexy. And if there is a rhegmatogenous RD with a posterior break or with a giant retinal tear, then we have to go for pars plana vitrectomy with endophotocoagulation. So that is what is asked in this question. There is a reg RD with a giant retinal tear, and that's why we are marking this pars plana vitrectomy with endophotocoagulation as the answer. So that's why this is the answer. Okay, so I hope you have understood this question. This is also again a difficult question. I just wanted to discuss a few things of which are like slightly difficult and kind of INI-CET type. Okay, one more question like this. Which of the following is not an acceptable modality of management for the condition that is shown in this picture? Which of the following is not an acceptable modality of management for the condition that's shown in this picture? So mitomycin C, excision biopsy, interferon, or photocoagulation. Which of the following is not used? Will you be able to tell me? Mitomycin C, excision biopsy, interferon, or photocoagulation? Okay, I'll tell you. First of all, what is the diagnosis? Most students, when they look at this picture, they think this is a pterygium. But this is actually not a pterygium. I'll show you a picture of a pterygium. See, this is a pterygium, where you have a fold, a wing-like fold of the conjunctiva growing onto the surface of the cornea. This is a pterygium. But what I showed you in that image, this is not a pterygium. This is not a pterygium. This is what you call as OSSN, that is ocular surface squamous neoplasia. So this is called as OSSN, ocular surface squamous neoplasia. Now, how do you know that this is OSSN and you don't confuse it with the pterygium? See, this pterygium, it has started from this corner and then it is growing onto the surface of the cornea. And now look at this. This is a mass here like this. You look at this mass here at the limbus. It's not starting from this corner and growing onto the surface of the cornea. No, it is a mass which is circumscribed at the limbus. You look at the surface is slightly irregular. And very, very important, look at these. These are the feeder vessels. These are the feeder vessels. So there is a mass which is well circumscribed at the limbus, and you have these feeder vessels and the surface is irregular. This is OSSN, ocular surface squamous neoplasia. So what are the treatment options? The treatment options are mitomycin, biopsy, and interferon. There is no role of photocoagulation in the treatment of OSSN. So in OSSN, we can do an excision with a wide local excision can be done. We can give mitomycin C eye drops. We can give injection of interferon alpha 2b. So these are treatment options. But photocoagulation is not a treatment option for OSSN. Okay. Again, another tough question. The last question. Which of the following is not an indication for the given prosthesis? Perforated corneal ulcer, ocular cicatricial pemphigoid, multiple failed keratoplasties, or Stevens-Johnson syndrome. Which of them is not an indication of this prosthesis? Which of the following is not an indication of this prosthesis? So what is this basically? This prosthesis that you see, this is called as a keratoprosthesis. In simple words, this is an artificial cornea. This is called as K-pro or keratoprosthesis, or it's an artificial cornea. So see, when you want to replace the cornea, what do? You You replace the cornea by doing a cornea transplantation with a cadaveric donor tissue, right? So we take a cadaveric donor tissue and we transplant the cornea when we want to replace it. But there are certain conditions where a keratoplasty has got a very high likelihood of failing. So when you know that the keratoplasty, the graft after keratoplasty is unlikely to survive and the patient is a monocular patient, it's a one-eyed patient where that is the only eye with some potential of vision, and you know that the keratoplasty or the graft will not survive, that can be a possible indication for keratoprosthesis. So what are these conditions? These are the conditions where keratoprosthesis can be tried or offered to the patient. That is ocular cicatricial pemphigoid, multiple failed keratoplasties, or Steven-Johnson syndrome. So in all these cases, you find that the cornea is opaque, but there is some potential for vision and the patient has got that only one eye which has some potential of vision, and you know that the ocular surface is bad, and if you do a keratoplasty it is unlikely to survive. So these conditions can be offered K-Pro, that is keratoprosthesis. However, in a perforated corneal ulcer, there is no reason to believe that a graft will not survive. So in a perforated corneal ulcer, that is an indication for penetrating keratoplasty, not for K-Pro. There is no reason to believe that after a perforated corneal ulcer, if you do a keratoplasty, the graft is not going to survive. So this is a condition, this is an indication for penetrating keratoplasty. The others are conditions where the ocular surface is not good and the likelihood of a graft surviving is poor. And if it is a patient with that eye with the only eye with vision potential, then K-Pro is an option for these patients. Okay, so like these are the questions I had in store for you today. So this is the rest of the INI-CET sure shot that is going to happen, and these are the dates when it will be happening. So this is going to be a very, very high yield series for all of you who are preparing for the INI-CET exam. So I would advise all of you to attend these sessions. They will serve as good revision sessions for all of you. And I hope that this session in ophthalmology that we did has been useful. I tried to revise some important concepts, and one advice for those of you who are going for INI-CET is most of the questions tend to be more conceptual rather than factual. So it is worthwhile to revise the important concepts, and also we will be having these gland tests, so this can help you to get into that in this exam environment, and it will help you to get a certain hang of the kind of questions that can be expected in the exam. So do participate in these gland tests and do attend this sure shot series, because it's going to be a very high yield series for all of you. So thank you very much everyone. You have been a very, very enthusiastic audience and you have helped to keep up the tempo of the class, and all the very, very best for your exams. Thank you and bye-bye.